Thanks. So first I want to thank Lisa Kearney who put this presentation together for me and then bowed out. But one of the most important skills for a policy and operations person is to be able to develop good relationships with people who do research and evaluation. So, and Brittany, come on up. I've asked Brittany Cornwell, who is part of the PCMHI evaluation team in Ann Arbor, to come and assist me with the parts of this that I don't understand. So I want to say something about PCMHI that's important, or at least important to me. We're about primary prevention. We're about helping. Our goal is to improve the health and well-being of the primary care population, not just the patients we see, but the entire population, by being there as part of PACT. And you've got me thinking now about, well, instead of seeing patients who screen positive, maybe we should have some other pathways into our care, have a threshold at which point we need to at least be informed about patients. But that's a whole nother thing. And one of the interesting features of PCMHI is that it was rolled out in all the wrong ways in VA in 2007. It was based on the very heavily evidence-based collaborative care model. And the weird thing that developed in an insignificant little VA in Vermont that seemed to work, co-located collaborative care. So despite the lack of evidence for the latter, it's widely adopted. The well-referenced collaborative care model is still struggling. That's a whole nother talk about why that is. So another thing is, part of what it's predicated on is having the services available in primary care at the time that the need develops. Maybe it's identified during a PACT huddle, maybe it's identified during the clinical appointment, maybe it's identified during screening. And we know that if we strike while the iron is hot, people are more likely to get care. No-show rates in primary care for people who need our services drop to zero, if it's right there. Unless the DAV van is leaving or something, and then there's other ways we can do what we need to do. But we've also shown that for patients whose needs can't be met in primary care, that their likelihood of engaging in specialty mental health care is much greater, if they've first seen us as opposed to being sent directly. So what we have not really addressed until now is, whether, beyond just the immediate continuation, whether people actually stay in mental health care once we get them into specialty care. It's all become, the MyVA Access kind of grabbed this thing years ago, 2014. So here's what we're going to do. It's a great thing because it increased the value and spread of PCMHI. At the same time, it had a lot of administrators using us for purposes of meeting a measure rather than improving the care in PACT. So there's also a lot of interest in use of mental health services based on race and ethnicity factors. And, we know a lot about this. We know that in most systems, underserved populations are primarily, some of these racial minorities, and it's less so in VA, but it's still an important area for us to cover. So I'm going to let Brittany take over the method section and explain it to me.
All right. Hi, everyone. So using VA administrative data from the corporate data warehouse, we identified 437,051 primary care patients that had an initial specialty mental health encounter in FY 2016. Initial meaning they had no specialty mental health in the prior year. And then we used multivariable logistic regression to assess whether the odds of getting a subsequent specialty mental health encounter within 3 months of the initial was greater for patients that had an integrated care encounter that same day, a day to 3 months prior, or 4 to 12 months prior. And then we also identified a subset of patients that had an initial PCMHI encounter, initial in this case meaning none in the prior 2 years, in the year prior to their initial specialty mental health encounter, and that was 226,006 patients. And for these patients, we also assessed whether they received a subsequent specialty mental health encounter within 3 months, and whether that differed by whether they had a same-day PCMHI encounter. So that means on the day of their initial PCMHI encounter, did they also get a primary care encounter that day? Ideally through a warm handoff from primary care to PCMHI with collaboration between these providers. And then we also assessed differences by race and ethnicity. So I'll run through the results here too. So recent PCMHI receipt was associated with greater specialty mental health continuation, so getting subsequent specialty mental health within 3 months for patients that had an integrated care encounter that same day, and for those who received PCMHI within a day to 3 months prior. And the effect of PCMHI a day to 3 months prior was greater for continuation of special mental health for non-Hispanic white patients compared to patients of another race. So the odds ratio of 1.72 versus 1.6. And then in those analyses that were specific to patients with the initial PCMHI encounter in the year prior to their initial specialty mental health encounter, the receipt of same-day PCMHI, so again that primary care PCMHI same day, was associated with greater specialty mental health continuation. And in this case, the effect of same-day PCMHI was lower for non-Hispanic white patients than other patients. Odds ratio is 1.1 versus 1.2, so kind of the opposite direction that we saw with the other part. Back to Dr. Pomerantz.
So talk about this a little bit, and one of the things I think a lot of people know about PCMHI is that it's not traditional mental health care. We know that most people who are referred for standard mental health care, like out in the community, go to the mental health center or community mental health center or whatever, or in the VA, go to Building 8, whatever it is. That most either don't show up or don't engage. I mean, no-show rates for initial appointments, are in the range of 40 to 60%, depending. And we also know from many studies that there's an inverse relationship between the amount of time you have to wait for your mental health appointment and the likelihood that you are going to show up. And we also know that most people who do show up actually only come for one session and never come back. So it's a huge unmet need in all populations, and particularly in these racial and ethnic minorities. And so we're seeing that by using this approach to treatment, starting simple with a problem-focused, brief 30-minute evaluation in primary care, supported by patient-reported outcome measures and other things, that we're actually getting people, engage, and particularly those minority populations. And that particularly if it's the same day, it's not always possible to do the same day. A DAV man is leaving. I got to go. But, well, could I call you? Or could our collaborative care manager call you, work it out somehow. A lot of other ways to do it, but certainly if we can get that care the same day before they have a chance to go home, get back in life, I think, well, maybe it's not so bad. Maybe I don't really need to do that, and go on. By doing it same day, it's much more likely than if it has to wait a day or two. So in conclusion, targeting strategies that increase engagement are really critical, given the fact we know that patients who are referred to mental health for intensive evidence-based psychotherapies, such as a good example is, CPT and PE for PTSD, that the people don't want to do it. Some do. I mean, I got to come every week and do homework and spend an hour to 90 minutes with you. People just don't do it. It's been particularly true for these last cohorts of veterans from Iraq and Afghanistan. We learned that 15 years ago when they started coming home. That they don't want. We're always ready for the next war, for the last war when the next one comes along. What was a lot of things that were true about the Vietnam era veterans are not true about the current crop. So we have, and by the way, we have developed, again, I said there was really no evidence for what we were doing initially. We've developed a lot of brief methods of treatment, 30-minute, 4 to 6 sessions in primary care for chronic pain, PTSD, et cetera, adaptations of the longer models. We know that people start with that or just start with us, that they're more likely to engage when the time comes. And so again, the third bullet is, that really this is a great approach to engage ethnic minorities. It's really important. It seems to have an effect. As luck would have it, I had a conversation with a facility a couple of weeks ago that was saying, hell no, we need 60 minutes, especially for the people who are minority patients, because they're used to getting short shrift, and so we need to give them more. That didn't show up. In fact, maybe the next step is to look at those data and see whether they correlate with session length. I don't think they do, but I've been proven wrong before. And then finally, I think I already said the fourth bullet in other words. So I think we have a little time for questions. Plus, I think I have time for questions for the whole group of presenters.
Yes, you've got a little time and then we'll invite everybody to come up. So
Okay. I have 4 minutes and 30 seconds. Yeah, but we're wasting. Yeah, John.
So what's the mechanism of action? Why do PCMHI patients more likely to go into mental health? You could hypothesize the opposite. A little bit of PCMHI reduces the severity level if you don't need.
Well, these are the patients who we feel, or the patient feels, that we have not been able to meet their needs in primary care. That we've tried what we can, but this is somebody who actually needs something more complex, the one we're able to offer. They need a broader team, need more specialized care. So that's the slice. These are just the people who who were thought to be in that category, who were referred on. A lot of patients, and depending on, the literature ranges all over, everywhere from like 90% of patients can be entirely managed in primary care down to 50. And I think it's quite variable. Some depends on how you define the population and whether you skim off schizophrenia, bipolar disorder from the top. So, I mean, I think that the mechanism is that a number of things. One, you've demonstrated that you're paying attention to what's important to them. You're not going off on this wild goose chase looking for lots of other things that may be important to me as the clinician because of my training, but are not important to the patient. So you're not kind of driving the way. It's a non-toxic effort, a first appointment.
So we trust.
Yeah, trust. And, some of the stigma is less too. And there are many patients who we think we really would benefit. I remember these conversations. You would benefit from going to specialty mental health, and it's, hell no, I won't go. Yeah. Okay, well, I can't give you the same level of care here, a little shared decision making, informed consent, but we'll do what we can. And sometimes they eventually say, yeah, okay, maybe okay, I'll try something. Or even better, from my perspective, and what we're trying to do is bring more of those specialized services into primary care. There's a subtle but very important change in the next edition of the handbook, or call it a directive now. You won't find the words common, uncomplicated disorders in primary care. You will find conditions that can be managed in primary care. And so that depends on staffing and what you can bring in. And if you can bring in some specialty care, it may not be a 534 stop code, some of what you're doing, but if it's there, it's and available, probably more likely. So that's, a lot of people won't notice that wording, but it's based on a lot of complaints I was getting from primary care about, they won't help us with opiates, they won't help us, but it's there.
You didn't present on this, but I was wondering if you looked at the number of PCMHI visits matter for
no, we haven't done that. But it's an important point. I mean, that's another, piece of all this. There are a lot of PCMHI folks who say, well, I can only see this person 4 times and then I have to refer them. What we've tried to do is steer away from hard and fast criteria for when to refer somebody. I mean, I would think it's obvious if your PHQ score is steadily going up and now you're suicidal, that it might be a good idea to get some more intensive care. Some do it by diagnosis. I have one patient with schizophrenia who lives under a bridge. Another one who's a computer programmer, is well managed in primary care. Yeah, I talk to his boss occasionally. But, so Yeah, so the actual numbers of sessions we haven't looked at, but it might be a good idea. I'm 2 seconds over.
You're self-monitoring, luckily.
It's the only way.
I'll invite all our speakers up.